A 48-year-old man presented in November 2009 with decreased visual acuity, painful ocular movements, photophobia, and inferotemporal visual distortion. This was associated with mild ataxia and a 9-day history of severe, dull, frontal headache not worsened by the Valsalva maneuver. He had no past ocular history, and his medical history consisted of sciatica and psoriasis. Ocular examination revealed decreased visual acuity 6 out of 24 OD and 6 out of 6 OS. Dilated fundus examination revealed an isolated finding of bilateral optic disc swelling, the right more than the left, with associated splinter hemorrhages on the right. There was no evidence of restriction in ocular motility, such as the sixth nerve palsy, which is known false localizing sign for raised intracranial pressure, nor was there any other cranial nerve palsy identified. Reliable Humphrey visual tests showed bilateral diffuse field loss. Following admission under the medical team for presumed raised intracranial pressure, beta blockers were commenced to relieve the headache, and radiological and hematological tests were performed. Chest X-ray and computed tomography were inconclusive. Magnetic resonance imaging of the head and orbits showed only nonspecific changes that did not appear to be of clinical significance. Ventricles, basal cisterns, and sulci were normal and symmetrical. Initial blood tests, including autoantibodies and syphilis serology, were also negative. On review 2 days later, his visual acuity was further decreased, 6 out of 24 OD and 6 out of 36 OS. Ishihara testing revealed a significant decrease in color vision and a 4 out of 14 OD and 3 out of 14 OS. Intravenous high-dose methylprednisolone was initiated, 1 gram daily for 3 days, followed by oral prednisolone, 40 milligrams daily, tapered by 5 milligrams weekly. A lumbar puncture was performed, which revealed a normal opening pressure, helping to exclude palpedema in the presence of findings of bilateral optic nerve swelling. Further analysis of this cerebrospinal fluid found white blood cells and glucose levels to be within normal limits, and there was no evidence of microorganisms on microscopy. Red blood cell count was slightly elevated, but in the absence of intracranial hemorrhages on cranial imaging, it was likely that this was secondary to a traumatic tap. Further blood results revealed a positive result for B. Burgdorferi by Lyme enzyme-linked immunoabsorbent assay and Western blot serology. The patient had no recollection of any recent tick bites, but had sustained bites previously. Therefore, the diagnosis of Lyme disease was made in the absence of erythema migrans, because there was a history of exposure to an endemic area, involvement of at least one organ system, and a positive result from the laboratory. The prognosis was Lyme disease.